I'm Humphrey. I'm a GP at Nethergreen Surgery. I've been a GP for 12, 13 years, and I've been a cases GP in general surgery since it started. And I'm joined today, really grateful to be joined by Simon Boys, who's consultant general surgeon and major trauma surgeon at Sheffield Teaching Hospitals. He was also clinical director of general surgery for almost a decade, so he gave that up last year. I'm really pleased to say that Marion's got so much knowledge about gastroenterology. I do not have so much knowledge about hernias, but Simon has that knowledge, which is why I've invited him to come along today. So just a little bit of an introduction from me first before we get into some details. So there's loads of resources available for all of you when you're thinking about referring somebody with a hernia. I know before I started with cases, I just assumed that if they had a hernia, you just sent them to the surgeons and they repaired their hernia, but there seems to be a lot more to it than that. So places where you can get some further information, you may already access this, obviously the press portal, the PCS website, and funnily enough, Sheffield Aches and Pains website. So on the press portal, some of you use this already. There's a surgical repair of hernias checklist and referral form. It's not a compulsory form. I think it's one of these forms that pops up if you type hernia in on system 1 and you have to close down the pop-up. One of those really annoying pop-ups. But it is a really useful checklist if you're not sure whether a hernia needs to be referred or not, because it does give the guidelines about which hernias do need to be repaired on there, kind of a broad brush stroke. There's also the groin pain hernia pathway, which is something that Simon and colleagues came up with just as a helpful pathway for those people who are presenting with groin pain. So a lot of people present to primary care with groin pain, and you'll all know that if they've got a soft squishy lump there, it's pretty easy to say that's a hernia. But a lot of people on examination won't have anything at all. You won't be able to find a hernia or a lump or maybe even any tenderness. And actually, what do you do with those? Do they really have a hernia? What's causing their groin pain? And so this is quite a useful pathway to look at, and we'll talk a little bit about that in a minute. And there's also making a decision about inguinal hernia information sheet. So this is quite useful. This is a really detailed document that you could give to patients. You could have a read yourself as well, because there's loads of information in there, but it's something that you could forward to patients for them to have a read about, so they can learn about their inguinal hernia and make an informed decision about whether they really want it repaired or not. On the PCS website, we've got the top 10 tips. I couldn't think of 10 tips for hernias, so I think there's about 8 or 9. And there's also a link to the groin pain pathway. And on the Sheffield Aches and Pains website, it's now called the Groin and Young Adult Hip Pain. They've recently updated that to include the young adult hip part. But this is where, if you use the groin pain pathway, you might signpost patients to get some info who may have musculoskeletal groin pain. So groin pain isn't always hernias, and it's the useful resource for them to maybe try some exercises and stretches to help rather than being referred. So this is where I'm going to get Simon involved with his expertise. I think we've got to share the microphone, Simon, okay? So first of all, if you can just give us a bit of an introduction to kind of what's happening at the moment with hernias in Sheffield.
Yeah, I mean, from our perspective, it's mainly just Sheffield Northern General where we do most of our operating. So on average, we operate on about 620 hernias a year. The current time, about 50% of those will be inguinal hernias. The current waiting list is sat between 40 and 50 weeks. It doesn't necessarily mean your patients are going to wait that length of time, because sometimes we do end up having to expedite them. But the longest wait at the moment is 65 weeks. So it's quite lengthy. And I think just jump to the next question is that there are alternative providers. There are some slight caveats to that, actually, because those alternative providers are One Health. One Health are probably fairly selective in the patients that they'll take. So if you've got a patient who's got comorbidities, elderly, pacemakers, all those sort of things, then all you'll end up doing is they'll get referred to One Health, they'll get referred back to you. I don't know why they don't just send them to us. They'll get referred back to you, and therefore they go through the cycle to be seen at the Northern General. But if you've got young, fit patients, then they've got a significantly lower waiting time than we have at the current time. Obviously, if you send everyone there, it won't be long before their waiting time is starting to match ours. You could send them to a wider sort of Barnsley, Rotherham, Doncaster, who have slightly lower waiting times than we have at the current time.
So for those of you that's referred hernias in, you may have got replies from me saying maybe this hernia doesn't need to be repaired. So Simon, can you just tell us a little bit about which hernias should be repaired and which hernias shouldn't be repaired or don't need to be repaired?
I suppose the general thing is no hernia really needs to be repaired, especially if they're asymptomatic. However, there are obviously lots of caveats associated with that. Certainly those who've got pain, and there are certain hernias that we would say would definitely need operating on. So the caveats are a femoral hernia and also Spigelian hernias. Spigelian hernias have a problem by the fact that they'll have a defect, but it's usually entrapped underneath the external oblique aponeurosis and therefore can be at higher risk of strangulation. But the risk of strangulation for any hernia is probably only about 1 to 2%. Obviously, if a patient then comes in as an emergency with bowel obstruction, that's an emergency operation and carries a significant amount of comorbidity with it, because usually they tend to be on the older end of the spectrum. But in general, if you've got an asymptomatic hernia, then they don't need to be operated on. Certainly from a cosmetic point of view, certainly very large hernias, more can be a functional problem rather than anything else. So it may not just be purely pain. It may be that their core strength is getting worse. They're not able to get off the floor. They have to roll out of bed. And certainly that can be associated with divarications as well, particularly in postpartum women who can struggle in that aspect. We can repair those, and to be able to return core strength is probably a good way, because as people get older and more frailer, obviously there's a significant amount of that comorbidity that we'll get as they get older is related to their ability to have core strength and increasing frailty with these issues. So it's mainly pain and from our perspective, subacute obstruction or obstruction for those patients, but there's no blanket requirement for a patient to have a hernia repair, particularly if they're symptomatic. And certainly, if you go talk about the small ones, umbilical hernias that are an incidental finding on an ultrasound scan with a 5mm defect, we probably would do more harm by operating than we would by just leaving and watching and waiting. And obviously, if they get bigger and more symptomatic or focally symptomatic, then that would be a reason to refer them in.
And what about you mentioned we often do ultrasound scans for something else, and we'll get on the report that there's an irreducible 1 to 2 centimetre umbilical or paraumbilical hernia. What would you do with that? So, what do you recommend? Or what do you recommend we would do with that?
Probably nothing if they're asymptomatic. Certainly at that size, they're not going. Irreducible always puts fear into people, but usually that irreducible is due to the fact they've got preperitoneal fat in there, or they may have some momentum in there. It's very unlikely at that size they're going to get bowel in it and obstruction from that point of view. So it is safe to leave them alone at that time. However, if they're getting significant pain and discomfort and it's having an impact on their quality of life, we will operate on them.
So another big factor, one of the reasons I send messages back to GPs who've referred in is either because you've not mentioned their weight or their BMI, or you have mentioned the weight and BMI and it's raised. So can you just explain why that's important?
The biggest factor for hernia development is obesity. The issue with operating on patients who have got BMIs of greater than 35 is that there's a 50% increase in recurrence rates. They also have a significant, to be fair, there is a slight spectrum up from 30 onwards, but we're more or less around 35, is that there is a spectrum up there of increased risk of surgical site infections at the time of an operation. And that complication risk can go from somewhere around 15% to BMIs up to 70 or 80%. If you get a surgical site occurrence or infection, then it increases your risk of recurrence. If your hernia comes back and every time you operate on it, there is a significant increased risk of recurrence of that hernia. So that by the time you get to your second and third operation, then the chances of your hernia coming back are not insignificant. So the ideal situation from our perspective is that the first time we operate on them is the last time we operate on them, and that's one of the reasons that we're very keen on making sure that BMIs are at a level that we can be reasonably confident that the chances of recurrence are a lot smaller. So if you take it that normal weight individual with a fairly large ventral hernia or incisional hernia probably carries a risk of around 7 or 8% chance of developing a recurrence of their hernia within 5 to 10 years. That risk with a BMI of greater than 35 is probably somewhere around about 15 up to 21% chance of a recurrence of their hernia.
Sorry, Simon. What is the in terms of BMI? What's the position at the moment?
So we work on the principle that we won't offer an elective operation for somebody. There's a caveat to this, with a BMI greater than 35. So it's really around the weight loss and getting them to a BMI below 35 before we offer surgery. The caveat is that if people have made the effort and come down with weight but are unlikely to achieve a BMI of 35, then we will review them and see what the situation is, because they've managed to make some lifestyle changes to improve their chances of success. Laparoscopic surgery, as long as the defect is relatively small, can be done in fairly obese patients up to just below 40. Really, anything above that, then the risk of recurrence significantly goes up again. So the threshold is 35, but we at the moment are saying somewhere between around 36.5 to refer in. Obviously, if you're concerned and your patient's made their effort and they're below 40 and they're increasing symptoms, then we will happy see them if they've been through a process of weight loss, because then we can make a value judgment of whether we're going to gain benefit with that surgery at that particular time.
Thank you. So this kind of moves on a little bit. We talked about weight loss. What are the things we've got a waiting list? That somebody's going to wait for a year for their hernia surgery. What else should we be encouraging them to do while they're waiting?
The other factors that influence healing and from a hernia surgery, because certainly when we're doing major abdominal wall reconstructions and things, that we're making skin flaps. So smoking is a significant impact on wound healing, and it probably has an additional 10% risk of developing surgical site problems at that stage. Now the debate is that smoking, or does that mean a patient can vape or be on nicotine replacement? Ideally, they're not on anything, because nicotine can cause some vasoconstriction at the site of healing. However, there is some debate that actually nicotine reduces the length of inflammation, so healing could be quicker. So it's a bit of a moot point, but it's certainly around your recovery and reducing your risk of surgical site problems by not smoking. And we advise patients to, preferably for major reconstructions, not smoke for two months. For smaller hernias, then around about 4 weeks prior to the surgery, and preferably for another 4 weeks afterwards. Obviously, it'd be ideal if they never smoked again, but you never guarantee that. The other factors are diabetes. It's a minor issue, but if they've got uncontrolled diabetes, it adds another 5% risk factor to you developing surgical site problems, and then obviously surgical site problems result in an increased risk of recurrence of your hernia. So we prefer, as the standard is, that the HbA1c is preferably below 70. If we can't manage that, then obviously we'll operate on a patient at that stage. And the other is physical activity. Encouraging physical activity is known to make a significant improvement in outcomes for surgery, whether that's hernia surgery or any surgery.
Thanks, Simon. Emma's told me I've got 5 minutes, less than 5 minutes left, which is a good job because I've got to go and pick the kids up from school. I suppose a lot of those things I kind of think about that when we're referring somebody for surgery for a hernia, could we be having, because it's often not a difficult consultation, is it? They've got a hernia, so we'll refer you. Maybe we, as GPs, could be thinking about some of these things when we do that referral. And I know we got lots to do, but it's just one of those other things that Marion talked already about, all those risk factors for GI cancers and GI problems. But so as holistic care, maybe we could be thinking about that when we refer. A couple of quick questions then. Do we need to arrange a scan?
No. In short. If a patient's got this issue, if they've got an obvious lump or they've got an obvious inguinal hernia and symptomatic, refer them in. The biggest problem we have from a scan perspective, ultrasound, is it's got a very high false positive rate for hernias. So they'll come and see me in clinic, and I will examine them. I can't feel a hernia. The ultrasound scan says they've got a hernia. The patient thinks they've got a hernia. There could be musculoskeletal factors that are associated with that. So I usually arrange a herniagram. So herniagram is probably more of a gold standard for defining whether they've got a hernia or not. However, that still picks up very, very small hernias. So out of the 100 that we've done over the last 2 years on the background of ultrasound, 66% of those showed no evidence of a hernia, even though the ultrasound scan did. 33% of those, 10% were equivocal, and that was is possibly, maybe, could be, but was extremely tiny. And there was about 20 to 25% that suggested that there was a small hernia or a hernia there on it. Going through those, there's probably about 10 of those where I think, well, I don't know why I missed that hernia, and then the rest of them are very small. It's difficult to know whether a very small hernia has a significant impact on people's chronic groin pain. And the feeling really is that there may be a more musculoskeletal cause in those patients, whether that's weakness within the inguinal muscles around the transversalis and the conjoint tendon, or whether it's adductor tendonitis. And so that's why we're really keen on sort of the physiotherapy aspects, the strengthening and conditioning work. And then, but I think it's also getting people's expectations or patients' expectations about what they're going to achieve. I mean, I do some work with the sports and exercise medicine, and certainly with adductor tendonitis or inguinal pain, they're advising them that it may take 12 to 18 months to make any significant improvement. Obviously, if they're developing a lump in that time, then we'll happy to see them and operate on them. If they've still got symptoms at 12 to 18 months and there is a feeling that might be a hernia there, we're happy to see them and consider surgery at that particular time, because they're not making the progress with their exercises. Whether patients actually follow what the physiotherapists say, I'm not entirely sure, but.
So we talked a bit about that. I think we haven't got time to touch on it again, but I think this question is about they've got groin pain but no hernia. That refers back to that groin pain pathway we looked at the beginning. So if I don't know how long I can let go back to that. It was this one coming up. So you can see here, groin pain. Have they got a clinical hernia? Yes, you go down this side of the pathway. Have they not got a clinical hernia? You go down this side of the pathway. Lightly musculoskeletal, no imaging required. Consider analgesia, look at the Aches and Pains website. Review in 3 to 4 months. And then we've got a little bit here about when you review them, have they got that lump? Has a lump appeared? Because some of them will be hernias, they just will be really early hernias. And if they have got a lump and they've got pain, then you can refer them back in. Right, let's see if I can whiz through to the end. And that one. We still don't need to arrange a scan. Another question we get asked is about truss or orthotics. Is there any reason to use those?
For ventral or very large ventral hernias, then an abdominal corset can help significantly with symptom control. Trusses are a bit more of a... Some patients find them helpful. I think a lot of patients don't. They find them very cumbersome. But we do arrange through orthotics to have them supply if a patient wants to try them. But they can be helpful in cases, and in other cases the patients just don't get on with them at all.
So as GPs, we can refer directly to orthotics. So I think there's a form, but I think they just accept a letter as well. So if you've got an elderly person who's not fit for surgery but have got an uncomfortable hernia, they could try a truss or orthotics, and we can refer directly for that. And that's it. Any questions for Simon? Not me.